Now, for those of you who don't know me, my name's Jo Gibson. I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit, funnily enough, in Liverpool in the UK. And also I work as a consultant in private practice. And these Monday Facebook Lives are just my opportunity to talk to you about some of the interesting cases that I see, share some clinical tips and tricks, but importantly, just kind of spread the shoulder knowledge, if you like, and be here to answer your questions. This week, I thought I'd talk to you about a really interesting case that I saw a few weeks ago. Actually, I had seen this particular condition once before, and I learned a huge amount from it because, one, it was something I hadn't seen before. It was in a group of athletes that I don't see many of. And actually, I learned an awful lot of things that showed me where actually things can go wrong, and athletes can miss out getting perhaps the necessary treatment that they need. So this was a 25-year-old young lady. She was a weightlifter. She's at a high level in terms of her weightlifting. She's weightlifted since she was 15. Always been very sporty. She comes to me with an 8-week history of pain. Now, this girl has been having physiotherapy. She describes an insidious onset of shoulder pain, which she locates very much to her posterior shoulder, some that she feels kind of is above the clavicle, some at the base of her neck, and she does get some upper thoracic pain. She went to see a physiotherapist who sent her for a shoulder x-ray because she just wanted to rule out a stress fracture, and there was no evidence of any first rib stress fracture. The clavicle was fine, etc. So she had some physiotherapy. She was told to stop doing her weightlifting. She stopped it for 2 to 3 weeks, went back, started lifting, and had exactly the same symptoms again. Now, when I really drilled down to the detail, she definitely had some ongoing pain, but then she'd be doing clean and jerk one day and had a really quite sharp pain, which she localizes in this region here. In terms of what she'd been doing physio-wise, she'd done some scapular setting, she'd been doing some cuff-related exercises. But as I say, as soon as she goes back to loading, then she starts to get that problem. Now, for me, obviously, I want to put the clinical picture together as well. So when I assess this girl, if she does rotation or lateral flexion to the side of her pain, it's stiff and it's uncomfortable. If I palpate over trapezius, it's generally tender, but also if I palpate, now again, we can have a great dialogue about whether I think I can palpate rib 1, but essentially if I come anterior to trapezius and palpate along what I perceive as a ridge there is a pinpoint tenderness. Now, what am I thinking? Well, I'm thinking that the physio that's seen this girl before was probably on the right lines in terms of we've got very local pinpoint tenderness. We've got somebody who does really heavy lifting as a competition and has recently increased their training load. They're not responding to a short period of rest. But I've got an x-ray that says that the first rib looks absolutely fine. So, of course, I do my other testing. And there's no doubt when I look at this lady's deep neck flexor strength, which I looked at formally, because obviously that's important in a group that are lifting above head, particularly with big loads. And it was poor, really, for somebody at her level of competition. Similarly, I always do my prone cuff test. And again, she was significantly poorer performance on that side. I wouldn't necessarily say weaker, but there's no doubt the cuff wasn't doing its job as effectively. Now, she didn't have a pain that she could reproduce. It was more at the end of clean and jerk and loaded activities, or it built up during a training session. But when she showed me her clean and jerk and some of her other techniques in the clinic, just with a free bar, no major weight, then you could see there was this real tendency that everything was done really sticking her chin out and really kind of dumping her shoulders away from her neck, and potentially creating load around there. So, okay, I've got somebody who's got some neck stiffness and palpation findings, but I'm still highly suspicious of this first rib stress fracture, because she gives me such a typical history. Now, stress fractures actually in the upper limb in the skeletally mature athlete are pretty rare. Dudson asked a question last time and said, is there evidence about stress fractures in the skeletally mature athletes? And if so, is there an association with GERD and fatigue? Now, most stress fractures, there have been suggested links with fatigue, with some biomechanical or neuromuscular deficits, if you like, but as ever related to load, genetics, all the things that we'd associate with overuse issues that we've discussed in the last 2 weeks. Now, again, if you look at stress fractures in the upper limb, again in the skeletally mature, if you look at acromial stress fractures, then really we see those most commonly in older patients who have a reverse total shoulder arthroplasty, and there seems to be a bigger risk of getting an acromial stress fracture in ladies the older patients are, but also some technical features about how the actual arthroplasty is done. If we look at the coracoid, we can get some coracoid stress fractures, but again, they're very rare. Similarly with clavicle stress fractures in the skeletally mature. And if you look at the evidence, really, they're very small case studies. So in terms of answering Dudeson's question, there's no doubt a link with load and fatigue, but in terms of a direct research project that's looked at the association with GERD per se, that's not been done. But remember last week, we talked a lot about GERD and said that actually it's a very effective measure of fatigue if we have change, and particularly if we can change it and measure fatigue recovery. Now back to my lady. So as I say, upper extremity stress fractures are far less common than lower extremity stress fractures, but interestingly, stress fractures of rib 1 are one of the most common that you'll see in that weightlifting population. No great surprise if you've tuned in for the last 2 weeks. They're also common in pitchers and baseball players. Now again, you can see a lot comes out of baseball, but it is a growing sport in this country. Now interestingly, if you look at case theories, there's a couple of papers, generally I'm trying to pronounce this guy's name, Funkashura and Kawashima, I think, one last year, one this year, and I'll as ever, I'll put links of those on the Clinical Edge Facebook page. But again, small series, 23 patients, average age around 18, but the age spectrum from 13 to 25. Now, I had seen a girl with this before, and one of the key things that I want to share with you tonight is an AP of the shoulder is not sufficient to rule out a rib 1 stress fracture. One of those papers that I quoted essentially showed very clearly that if you only use an AP of the shoulder, then you only visualize the first rib in 47% of the cohort in their study. If, however, you did an AP of the cervical spine, so it's a slightly different projection, then you visualize the first rib in 97% of cases. So just that very simple thing. So remember, I've got this girl, she's got lots of things that tick a box that I'm strongly suspecting a rib 1 stress fracture, the mechanism of onset, the location of pain. And in terms of the location of pain, again, if you look at these case series, they talk a lot about upper posterior thoracic pain, obviously the kind of trapezius and superior clavicular pain, but some of these patients also get infraclavicular pain and it can radiate medially. But again, both those studies would suggest that if you have somebody that does repeated loading, has had any change in loading history, and has particularly that posterior shoulder pain and any base of neck pain, that you should be strongly suspicious of ruling that out as a diagnosis in these athletic populations. Now, because of this, and because I'd seen another patient with the same presentation a few years previously, I sent this lady for an x-ray of her neck, and sure enough, she had a stress fracture. Now, CT is also very useful in this population. What's really interesting is if you follow, again, some of these case theories, and when I looked to the patient that I saw the first time round with this condition, anywhere between 30 and 50% of these patients will never fully heal, even if you rest. But the good news is that doesn't mean they can't get back to their sport. So the original lady I saw probably 2 or 3 years ago now, again, top of her game in terms of competition, lots of scans following her up, trying things like biphosphonate infusions. There's a case series using low intensity pulsed ultrasound, again, to try and promote fracture healing. But what's really interesting is in patients who develop a pseudoarthrosis, so they get a fibrous union, they don't get any real callus, they can get back to their previous level of performance. So the important thing in terms of monitoring these athletes and re-imaging them is essentially we check there's no displacement, there's no widening of that fracture size, and it's unchanged, and match that with their clinical symptoms. So if you like, the lady that I saw originally came to see me, we did rehab, and I'll talk about the kind of fundamentals of what I did. And she did very, very well. But when she had follow-up imaging, there was still a fracture there. And so I spoke to one of my radiology colleagues who suggested repeating the CT, and it actually did an MRI. And actually there was clear fibrous union. And what was important when you looked at the CT series, that fracture had not changed, i.e. it hadn't moved, it hadn't got wider over time. So the key thing then clinically was there was no palpable tenderness, we couldn't reproduce symptoms, and so again we kind of let that athlete get back, and they got back to their previous level and actually broke personal bests without any recurrence of symptoms. Now there's no doubt that the risk of that pseudarthrosis is a higher risk the younger you are. So under the age of 20, you're more likely to be in that 50% that have a pseudarthrosis. But this is where in these days where imaging gets such bad press, actually in combination with our clinical examination, it can be hugely helpful in these very specific athletic populations. So this 25-year-old, we sent her for the AP of the cervical spine, we proved she'd got the stress fracture and she had a CT. So we've now got a great basis on which to monitor. So the key thing is, what do I need to think about in terms of what might give me best value in terms of rehab and what causes these stress fractures? Well, again, it seems to be a little bit of a design fault. If you look at the attachments of the scalenii onto the first rib, they attach either side of the grooves that basically have the subclavian artery and lower cord of the brachial plexus, and then another groove with the vein. And at this point, that's actually where the first rib is its weakest. Now, as well as you've got anterior and middle scalenii almost pulling in slightly different directions, you've also got serratus anterior and subclavius. And certainly when you look at the highest instance in terms of fracture sites being in that intertubercular region between those two grooves, then it would seem to relate a lot to, if you like, the stresses caused by those different muscles when it's under repeated load. So we've got this anterior middle scalenii, we've then got our serratus anterior and our subclavius, and as I say, there is some supposition. If you think of this girl that I've told you about who's sticking her chin out here and dumping her shoulders away, you can see that those muscles without a good stable base potentially are working against each other. Now everybody gets dreadfully excited when you talk about positioning with lifting and all those sorts of things, but I'm in a situation where I've got somebody who wants to get back to competition, and importantly I want to improve load transfer through that system. She's failed her prone cuff test, she's got some clear weakness in her deep neck flexors, clearly very strong in those superficial muscles, so I've got somewhere to start. And with somebody like this, I would go through a formal program of deep neck flexor strengthening, but also build in just cervical neutral with any through range shoulder work that I do, but importantly then progress her on so she can cope with the sorts of loads that she's having to do in her weightlifting. Now again, what I often find with this cohort is you do some very simple warm-up exercises, just short through range, short lever work, just reinforcing the cuff with a loop of TheraBand. And often you'll find if you go back to that prone cuff test, there's immediately a big improvement in their ability to do that test. So then, of course, I've got to test her under loads that, again, replicate the sorts of things that she wants to do. But again, with this cohort, I don't necessarily expect their shoulder to be weak. I just need to change that strategy. So what was really interesting with this girl, and just showing her strength in her start position for her lift, but then showing her the difference just by some very subtle repositioning, i.e. bringing her thorax to her shoulder rather than dumping it away, we got a massive increase in her external rotation strength measured on a handheld dynamometer. So we took her on this journey. Essentially, we did things like wall squats when we introduced load. We progressed her cuff strength. We did some eccentric work just because proprioceptively and getting that engagement in somebody who's done something for a long time, and we really need to engage with the brain. Eccentrics potentially give us some additional benefit. But we really did some very simple things. But the key was how she then warmed up for her training sessions. Everything really exaggerated that upper thorax with her cuff, with her cervical stability as she did her exercises, and then progressively increased her load. And importantly, she kept doing those things even when she got back to her sport. Now, unlike my first lady who had a pseudarthrosis, this girl actually got some callus and some nice healing, and actually got back to top level very well within a 3-month period. Now, just a couple of caveats. In some ways, a pseudoarthrosis is almost a better option. Why would I even say that? Well, because in a very small percentage of people who get this injury, if they develop too much callus, remember the things that I said sit in those grooves. We've got the lower cord of the plexus, we've got the subclavian artery and the subclavian vein. As I'm sure you'll know, in terms of that scalenii triangle, when we look at things like thoracic outlet, you can imagine if we get a lot of callus deposition, then potentially there are some small case reports of patients that go on to develop thoracic outlet syndrome as a result of callus formation around the rib site. So again, it's like the kind of cool thing is using our detective work to be aware of the sorts of patients that get this. And when we look at stress fractures of the first rib, the most common groups we see are certainly our weightlifters, certainly our throwers, and generally it's our pitchers, so those really high speed throwers. It has been reported in a couple of fast bowlers in cricket as well. But also interestingly dancers, in male dancers, in terms of loads of lifting. But as I say, in weightlifters, it's one of the most common stress fractures in the upper quadrant. So really what I wanted to share with you tonight is I think the first key thing is remembering that a shoulder x-ray is less than 50% accurate in terms of picking up those rib 1 stress fractures. So actually an AP of the cervical spine arguably is a much more reliable thing to be able to confidently say you haven't got one. But CT is really the recommended imaging of choice. And again, if you've got an athlete going back to competition, what you want to be clear about is that fracture hasn't got bigger, it hasn't moved. And if you've got somebody with lots of callus formation, is really monitoring some of those neural things. But to me, it's a time where actually improving the biomechanics kind of makes sense. In a world at the moment where we're told biomechanics don't matter, well, they don't matter until they do. And for me, what I want to do is balance out that activity of serratus and the scalenii and subclavius purely by making sure I get the scapula and the cuff working effectively together as a foundation, but also ensuring I've got adequate cervical stability and strength to be able to maintain that as she does all her different types of lifts. So I learned a whole lot about weightlifting. I was able to name all the lifts. I did a bit of homework, but I think again, this is where it's really interesting when you get a condition that you might not have seen very commonly, but actually learned loads from doing it. So I really hope that that's been useful for you too, and just something to bear in mind if you see any of those groups, but also importantly, the kind of typical symptoms that they'll describe. I think I've told you everything that I want to, and I'll come to your questions in just a minute. But as I say, again, it's a time for me where investigation is key. In terms of the low intensity pulsed ultrasound, there is some evidence to support that, increasing evidence. Again, it's not something that I've used particularly, but the first girl had it, didn't make any difference. Also had the biphosphonate infusions, didn't make any difference, but there are case studies in the literature that reported some positive effects from treatment. Now, guys, I don't think, we've just got a comment that the fibrous union in a pseudoarthrosis is similar to the elongation of the pars in spondylolisthesis. Marlene, could that be a temporary thoracic outlet in case the callus resolves? Do you know what the chance of... Oh, so Marlene, that's a really lovely question, but if you look at the limited case series there are of looking at patients who've developed thoracic outlet as a result of this callus, generally there is a low threshold to actually operate and do something about it, and often they'll either do a limited excision as well as remove the callus, because the problem is if they're laying down an amount of callus that's causing that thoracic outlet, you can't rely on that process to remodel, and so again it's thought to intervene early if they've got clear neurological signs. If you had somebody who just had irritation, they didn't have frank neurology, then I guess you could argue a case, but we just don't have evidence of that in the literature in terms of a wait and see approach. In the small case series that are reported, then generally in that very small percentage who do go on to develop thoracic outlet as a result of the callus, they have had some sort of active intervention. So great question, but the bottom line is I don't think anybody's looked at that long-term follow-up. And remember, this is such a rare patient group. You know, I've seen 2 in my entire career, and that's working in a specialist shoulder unit. But again, if you're working in sport, you never, or even if you're just working in normal clinics, you never know when these patients are going to come through, particularly with the current emphasis on strength and lifting and doing a lot of those compound lifts. So again, just something to be aware of. Now, guys, I'm just going to check if there's any questions. So my question last week was in relation to a 25-year-old male with a mid-humeral spiral fracture. The patient does low-level baseball in the UK. Interesting. So, yeah, the interesting thing, Dudson, in terms of a mid-humerus spiral fracture, again, without a clear mechanism, you'd want to just maybe, one of the things I didn't say was talking about vitamin D, calcium levels, those kind of things, because again, without a clear mechanism of trauma, certainly in my first lady, she was investigated regarding any contributors to poor bone health. As it turned out, she didn't have any, but I would really want to be drilling down if there was any other background history there. To see something to give me a few more clues as to why that might happen and rule out anything not very nice. So Almus, very helpful. Any tips on how we can mimic AP of the cervical spine when doing video consultation? If I'm honest, Almus, if you look at the evidence about repeated movements, the bottom line is that there was a nice study that hasn't actually made it to print yet. It was presented at a conference by David Vanderput, and he looked at the effects of repeated movement on shoulder pain and actually showed that even in people with no evidence of any cervical involvement, i.e. full range of movement, no tenderness if they pressed themselves or did repeated movements or postural correction, then repeated movements still had an effect on shoulder pain. So if you like, my go-to when I'm doing video consults is rather than get the patient palpating, is getting them to do repeated retractions, repeated rotations, repeated lateral flexions, depending on the history they're giving me, and seeing what effect that has, or even just doing sustained retraction. All these things have an effect on mobilizing the cervical spine, and again, a more active approach that I can then replicate in terms of the exercises I give them to do. Andy, could you add band to the barbell to induce some added cuff? Oh, love that. So absolutely perfect. So one of my favorite exercises with this cohort would be a wall squat. So essentially they've got the ball behind them on the wall, or they're standing against a wall. They don't have to have the ball, but it gives them a bit of feedback, doing that short lever and then adding load into that. But absolutely, when I then go on to free movement, so open chain without that reinforcement, 2 options. I can either put the band around the back and around their wrists, so they almost get that sensory feedback to their thorax and their cuff and their scapula. And it is sensory, but again, we know these things can have an influence on muscle recruitment, so that would be a really nice way of doing it. Or as you've suggested, perfect, just put a loop of TheraBand, so again, they're getting that reinforcement of cuff and scapula and reinforcing that foundation. So absolutely spot on. Charlotte, what would your opinion be on weight bearing through upper limb, in this case in a stable position? Absolutely great. And again, if you've joined us on these Facebook Lives before, you'll know we've talked about this huge dilemma about scapular dyskinesis. For me, anybody with first rib or clavicle type injuries, worsening scapular dyskinesis has been shown to be related to worsening symptoms. So in terms of if I'm doing a plank or a push-up, if they can do it, again, I might use my loop of TheraBand just to reinforce recruitment, but I do want that scapula to be flat on the chest wall when I'm doing those loaded exercises, because I reason there I'm coping with load through that upper quadrant. But absolutely, that would be a reasonable thing to do. David, hi. So with the baseball players, overhead throwers, what would your main differential between a cuff issue and the first rib fracture? Oh, so great question. So generally, in terms of the baseball players, we've talked a lot about the apophylaxis and clavicle and how they have localized tenderness. In terms of your baseball players and throwers who come with tendinopathies, then the most common in the younger populations there are long head of biceps tendinopathy. Smaller portion gets supraspinatus tendinopathy and those lateral epiphyseal injuries, the little leaguers that we talked about last week. So clearly their location of pain. When you look at all the studies that have been done about rib 1 stress fractures, the activity they do is an immediate thing that puts that in the ballpark of my decision making. That posterior shoulder pain and upper thorax pain has been suggested to be very pathognomonic. So as ever, the age, the mechanism of onset, and most it's insidious onset, but some you can get that kind of, they tell you they've had insidious pain in that area, but suddenly it gets worse with a particular loaded activity. So the age, the sport that they do, the mechanism of onset, and the location of pain are the things that would then make me go down the road in terms of my clinical examination. Now, again, remember that we said we can get that infraclavicular pain, we can get some pain posterior to the clavicle, and there are also studies that show patients describe underneath the scapula. So as you're quite right, it's kind of, well, how do I reason that out? If you look at somebody with cuff related problem or somewhere where it's just fatigue of the cuff and so they're getting tendinopathy in either supraspinatus or long-headed biceps, then they will fail all the same tests, but they won't have that pinpoint tenderness when you palpate through rib 1. They will, everybody with shoulder pain will have something to find in their trapezius, but again, I think that's where those cervical movements can be very useful. Now, there was a recent Delphi study by, I can't remember the name, I might have it written, Mastromarchi 2020, which was a Delphi study looking at assessment of the first rib. They described this cervical extension rotation lateral flexion test that if it's if it's limited to the same side, it's meant to suggest rib 1 restriction. But I think we have to be real honest about the limitations. I think for me, the key thing with that history, with somebody who's not responding, who's got such local symptoms, it's a bit of a no-brainer to get them investigated, particularly because it was a weightlifter and everything kind of suggested that. If I didn't have that localized tenderness and their pain descriptors maybe round here, but also in the arm, then I would be more likely to go on that journey in terms of addressing the shoulder. So I kind of hope that answers that. If not, you can ask me at work and tell me to do it better. But it's, as I say, it's the age and the sport could rule either of those things in. The mechanism of onset, again, you could argue is going to be very similar, whether it's cuff related, as in overuse fatigue, but the location of pain is a very useful one in combination with those things. So it's taking me more down one path, and then my clinical examination is going to prove or negate that. So great question. Thank you so much. And Marlene, thanks. Yeah, that makes sense. And thank you. I think, is that all our questions? Yes, I think it is. That was a great one to end on, David. Thank you in terms of differential diagnosis. So I love that question because it is all about putting the whole story together. And really these Facebook Lives are about giving you some examples, some interesting case studies, just to be aware of if you ever see any of these groups, and how you put that whole story together and decide or justify whether you're going to do imaging or not. But again, with this, both these patients, they had pinpoint tenderness, but the important thing was that having been through rehab, remember, one patient still had signs of a stress fracture that hadn't changed on CT with fibrous union, looked exactly the same on the actual x-ray, but importantly, no tenderness, passed all the functional tests and gradually increased her loading with no problem. So again, we've done stress fractures of rib 1 tonight. We've acknowledged some of the limitations. So that Delphi study talks about this cervical lateral rotation lateral flexion test, but actually shows that we don't have any reliability data. There's no studies actually looking at intertestal reliability. Well, there is, sorry, that's a lie. There are studies looking at intertestal reliability, and some studies showing that you get better reliability with your rib 1 palpation if you compare it with breathing and side to side. But as ever, we just need to be honest that a lot of these things are affected by how the muscle system are working. We get much better value by active treatment that changes what the muscle system's doing rather than lots of passive treatment. So some key clinical things to take away. Some awesome questions again tonight, guys. Thank you so much. Really hope I've answered your questions. If I haven't, don't hesitate to post something else on the Clinical Edge Facebook page, and I'll try and do a better job next time. Now, we had another few questions about language and how we describe shoulder pain. We also had one about brachial DVTs and more vascular related things, and I promise I'll get back to those in some future Facebook Lives. But to now, again, I've gone over my 30 minutes. I'll blame David for that one because it's such a good question and definitely worth answering in detail. But I'll very much look forward to seeing you next Monday, 7 o'clock, for some more shoulder geeking and sharing some more interesting cases. So guys, as ever, thank you so much for joining. Thank you to all of you that are saying thank you, and I really look forward to seeing you all again next week. Bye for now.